there was a substantial difference, 20% versus 47%. Numbers are small here, and as you know, there was a 2-to-1 randomization, so there's going to be more patients in the tucatinib arm. But in terms of complete responses, there were 3 complete responses in the tucatinib arm as opposed to 1 in the placebo. Then came the newest data, which is TDXD versus TDM1, Destiny Breast-O3. Breast-O2 was treatment of physicians support basis, but this was head-to-head in the second-line space. For example, patients who progress on Cleopatra-like regimen, previously the standard of care was TDM1, so this was a head-to-head trial to see if the standard of care needs to change. So these patients were randomly assigned in a 1-to-1 fashion to standard doses of TDM1 and TDXD. Primary endpoint was progression-free survival. Secondary endpoint was confirmed overall response. And you see here the result, there was a quadrupling of progression-free survival from 6.8 months to 28.8 months. Now again, why is this difference so huge between 2 antibody-drug conjugates? One is that there is twice as much payload in PDXD, 8 molecules of payload as opposed to about 6 molecules with TDM1. The other is patents, and the payload is a spindle poison, and most women are taxane exposed in the earlier settings. Therefore, for spindle poison, right after spindle poison is less likely than a non-cross-resistant drug like irinotecan, which is the payload of TDXD. So this is quite an unbelievable result. And for overall survival, which is immature, both lines are above the median. You still see some difference numerically, almost 70% versus 77.4%. So switching gears to early stage disease, which is where we actually save lives, I would point to these trials, none of which are new to you. This is ancient data, but HERA trial was all sorts of chemo regimens followed by observation of 1 year or 2 years of trastuzumab, while other studies had JRG allowed starting trastuzumab with the taxane portion of chemotherapy. And the right lower quadrant, BCIRD, had a novelty of providing TCH as one of the options, which was a non-anthracycline containing regimen, which was appealing because anthracyclines carry cardiac toxicity. There's also some cardiac suppression with trastuzumab, and therefore it's best to avoid anthracyclines if you're going to use trastuzumab. Now here are the results, updated a few times. This is the top 3 of the big trials, updated at 8, 10, and 11 years respectively. And if you look at the middle column, hazard ratios for disease-free survival, you can see that there was a quarter to a third reduction in the risk of relapse, and then p-values are highly statistically significant. On the right-hand side, you see overall survival with absolute reductions shown, and you can see that out of every 100 patients that you treat with the addition of trastuzumab, you save anywhere from 6 to 9 additional lives. Now, in the bottom 2 rows are smaller numbers, smaller trials, particularly FINRA, which was a very small trial and gave a short course of trastuzumab, creating a lot of confusion, leading to many trials to shorten the duration of trastuzumab from 12 months down to 6 months. But none of those trials fully met the non-inferiority criteria. And because HERA had shown that 2 years is no better than 1 year, we are now stuck with 1 year as the standard duration of adjuvant trastuzumab. Now, the addition of trastuzumab improved the outcomes, but there are still late relapses as shown here in this analysis. On the top, you see hormone receptor positive and negative patients treated with trastuzumab compared to the bottom 2 curves of chemotherapy without trastuzumab. So there is a need for further improvement, and to that end, pertuzumab was inserted in the adjuvant setting along placebo-controlled in this very large 4,800 patient trial called Affinity, and patients could be node negative or node positive, and they could have a tumor of any size if nodes were positive, but if they were node negative, then the tumor had to be larger than 1 centimeter in size. And I will show you the bottom line. There were many analyses, primary analysis, second interim analysis, third interim analysis, and they are shown here with hazard ratio improving from 0.81 to 0.76, and the second analysis remain stable. After that, curves separate late, but they keep on slowly separating. And as I will show you here, node positive group was the only subgroup that seemed to benefit on the left-hand side. Node negative group, which was 1/3 of the patients, seemed to derive no benefit by addition of pertuzumab. So we clearly should reserve this offering for node positive patients where 8-year invasive disease-free survival had a 28% risk reduction with a hazard ratio of 0.72. In absolute terms, there was increment of 4.9% for these patients, and now are almost 5. So you have to treat 100 patients for about 5 patients to benefit. And this difference had for both hormone receptor positive and hormone receptor negative patients. So hormone receptor status should not be a consideration in make this decision, but node positivity should matter. Neratinib was tried in the adjuvant setting in a different manner, in a sequential manner, because at that time it was standard to give everybody a year of rest. So the design of the study was to add a year of neratinib versus placebo. Despite all that diarrhea, there were a lot of instructions on how to control diarrhea. In retrospect, it seems like the best way is to start neratinib at 120 milligrams a day. In other words, start at half dose per week before you escalate into full dose. That is just about as effective as any other strategy. And tachyphylaxis to diarrhea develops in about 2 months, and then patients do okay. So they reported results in 3 parts: 2-year invasive disease-free survival, and 5-year follow-up invasive disease-free survival, and finally the overall survival. This took the exploratory invasive survival, overall 2.5% benefit, which translated to relative 27% risk reduction for all comers. So the drug got approved for everybody, and that's how the trial was designed, but it was very clear that the benefit was limited to hormone receptor positive subset, which is, as you know, 2/3 or more of the whole population. So majority of the population, if you exclude hormone receptor negative patients from the mix, then the delta improves to 4.4%, which translates to 40% relative risk reduction. So guidelines advise use of this intervention only for hormone receptor positive patients. And I will remind you, if somebody has been treated with an affinity-like approach with pertuzumab, trastuzumab, and they are very high risk, and we offer them neratinib, that is being done in a data-free zone because nobody the next study had given pertuzumab before. So we are on our own to extrapolate from the data. That's not data-driven. Now, simultaneously, there have been efforts to de-escalate therapy because patients with stage 1 breast cancer do very well with HER2 disease. You don't need to flog them with heavy chemotherapy and dual blockade. So previously, there was an APT trial, very large 400 patient phase 2 trial from Dana-Farber Sloan Kettering that showed that patients who get just 12 weekly doses of paclitaxel and 1 year of trastuzumab, they do just fine. They have 94+% long-term survival on your long-term data. This was an attempt to even avoid paclitaxel and just give TDM1 single agent for a year compared to that approach. We go up to have hair loss, which matters a lot to women to not lose their hair. So this is a alopecia-free regimen of TDM1, and it was supposed to be gentler in every way and just as effective. So we showed that it was just as effective at least as 3-year mark, where you see 3-year disease-free survival of 97.5%, and in tumors that are less than 1 centimeter, even 98.5%. But toxicity-wise, it had half the neurotoxicity of paclitaxel, but any toxicity requiring discontinuation was actually more with TDM1, and that was likely because protocol dictated a discontinuation based on rise of AST, ALT. In other words, liver function studies, which is a paper toxicity. Patient is not feeling any different if the AST or ALT is up. Lenient, not continue the drug, but protocol mandated it. So, as a practical standpoint, I think TDM1 is a good option for women with stage 1 breast cancer who do not want to lose their hair. Now, a word or two about neoadjuvant. I'm showing you the winning arms of the pivotal neoadjuvant studies testing addition of trastuzumab, pertuzumab in the neoadjuvant setting, and FDA agreed to use pathologic complete response as an endpoint worthy of FDA approval at that time, which was unprecedented in history of FDA approvals just based on PCR rather than disease-free survival or overall survival or PFS. So here in the bottom row, you see that PCRs are much higher in ER negative patients because ER positive patients are relatively chemo-resistant. So their PCRs are lower, but still far higher than patients where it's 10%. So when you're HER2 positive, you're chemosensitive, but more so if you are also ER negative. And then PCRs are, 2/3 of the patients or even more in the middle column, trifina. This is Luca Gianni's Neosphere. We had 4 groups. The winning group was group B, which got both antibodies with docetaxel, THP. That's the red line. The next group was a standard control arm of docetaxel with trastuzumab. The lowest 2 arms are docetaxel with pertuzumab. I told you pertuzumab by itself has no activity. And the other bottom arm is 2 antibodies alone without chemo, which was trastuzumab and pertuzumab. Now here, this is a 12,000 patient analysis of PCR from 12 different trials combined. The red line is those with PCR, and blue is those who did not. You see the delta between red and blue line is much greater on the right-hand side in hormone receptor negative patients who benefit more from chemo, as I previously mentioned, compared to the left hand where hormone receptor positive, but it's still good to achieve PCR. The point of showing this is, despite PCR, there are still relapses, and we needed to do something about that. So TDM1 was tried for that purpose in Catherine's study where patients who had residual disease after robust neoadjuvant chemotherapy either received TDM1 or continued trastuzumab to completion of a year without any TDM1, 1,486 patients, and it showed a 50% reduction in risk of relapse, hazard ratio of 0.5. On the right-hand side, you see the forest plot showing that all subgroups benefited because all dots are to the left of unity. Only the 95% confidence crossed that line where the subgroup size is very small. So currently, NCCN guidelines for metastatic disease divide the recommendation by line of therapy. First line is Bevacizumab regimen with a concession to give paclitaxel instead of docetaxel, which is not category 1, with no high level evidence in this. Second line, now TDM1 has been removed from that slot after the DB03 data, and category 1 preferred is trastuzumab deruxtecan. Third line is 2 options, either TDM1 or the HER2-Klein regimen of tucatinib, trastuzumab, capecitabine, which is category 1 preferred. And in fourth line, you have both post-op options. Any sort of chemo with trastuzumab or trastuzumab with atratinib without any chemo, neratinib, capecitabine, even margetuximab, which is STK inhibitor antibody of trastuzumab, which in some patients causes higher affinity of the molecule, and it's not been really adopted much in the United States. That's why I didn't talk much about it. So final section of the talk is at the request of Roche to talk about subcutaneous single vial tablet of trastuzumab pertuzumab. Previously, I've talked about all IV data of these drugs, but both of these options, single agent trastuzumab as well as the doublet of pertuzumab trastuzumab, which have been developed adequately with IV formulation, have now been tested in the subcutaneous formulation and are marketed and approved as such. This study, Frederica, was a phase 3 non-inferiority study assessing the pharmacokinetics, efficacy, and safety of its